Thank you so much, Dr. Supriya, for having me over, and thank Sri Ganesh sir also for always including me in this session. And it's unfortunate that he couldn't be here today, but we wish him well. So today I will be running through the overview of biometry devices, the kind of devices which are available to us, what it offers additionally, and how we can choose. So to very start with, I mean, we broadly have these ultrasound biometry devices which have always been there. Most of us have moved on to optical biometry, and even in optical biometry, we now have a combination of topographers and tomographers which are able to add to the biometry data itself. If we start with ultrasound, I think it still has a role to play in today's day and age. It is still not a tool we can do away with. Yes, no longer should we be practicing contact biometry, but definitely immersion, if done properly, can give excellent results and has been shown to be within a 0.1 millimeter of optical biometry when it is done by a safe and repeatable biometrist. Getting a good high quality A-scan with the right spikes is important. Looking at slightly adjusting the gains, higher gain for better sensitivity, lower gain when you need better resolution, denser cataracts increasing the gain, decreasing when we have artifacts like with silicone oil. Using all these small tips, we can improve our outcomes and efficiency even with ultrasound biometry and get excellent results. However, there are some situations where there may be some limitations, especially when you have a highly myopic eye, where the visual axis and the anatomical axis may not match, because in a staphylomatous eye, the anatomical axis is a little more posterior than the visual axis, and this may be a little bit of a challenge. Whereas with optical, because we are depending on patient fixation, it still gives us accurate measurement at the fovea. And this is one of the main advantages that why you would probably want to move into an optical biometer. So let us break it down into various components of biometry and how each of the devices compare. We'll start off with keratometry, which is possibly the most important variable as far as deciding or optimizing our outcomes with cataract surgery is concerned. A manual or auto ref can give a fair initial idea before you start with anything, before you even look at the cataract, to actually have this data, because ideally this should be done as the first test before anything else has been, even a dilating drop has been put in the eye, because only if you get an accurate measurement, repeatable measurement with this, will you be able to go forward with accurate calculations. There is excellent agreement between all the devices, any type of optical biometer that you may consider, whatever has been published in literature. Tomography is also useful, especially in post-LASIK patients. All the major tomographers, Pentacam, Galilei, Sirius, all give repeatable values. However, all our regression formulae are based on central data. And that is why we still prefer the keratometry taken from biometry devices rather than from tomographers from the SIMK values, which gives us a more average over a larger area of the exposed measured cornea. While this may be accurate in the keratometry itself, it's not directly applicable into the formulae. Looking at specific devices, like I said, generally they focus between the 2 to 3 millimeter area depending on the device that you're using. The number of points may vary, but it's this 2 to 3 millimeter area which is most important, which is what all our formulae are designed for. Additionally, a concept like the telecentric keratometry, especially in IOL Master, really helps, because even if the patient is not a little cooperative or your biometrist is not as talented, it ensures that the spot spacing is kept the same irrespective of the device to eye distance. So this is very important, because even if the patient is moving their head a little bit or is not rested completely, you still are measuring over the same region in the cornea and you get more repeatable values. That's one very important concept with telecentric. Going further, we have this total keratometry concept, where essentially we all understand the importance of measuring the posterior cornea, especially for toric IOL calculations. And the total keratometry, it gives us a toric model where it measures the central 3 mm cornea and also gives us the posterior torus fit. That is, it measures the posterior points directly on the from the posterior surface of the cornea. And while we did already have devices which could look at the posterior corneal power and posterior corneal astigmatism, it did not give us a symmetric measurement between the anterior and posterior. This is really important because then we can now devise formulae based on this total keratometry, and these total keratometry formulae are ULIP compatible, and so you don't really have to change clinical routines to measure it. Like I said, while Pentacam and Galilei gave posterior corneal astigmatism, they were found to be less effective than the assumed values which we got in the Baylor or Barrett nomograms. The mathematically derived values were better than the actual measurements which we got from Pentacam and Galilei, because essentially the formulae were not designed for these devices. So that is where the biometric devices which measure the central 3 mm, give us the posterior torus fit, and give us formulae which are applicable for this, have a greater edge over the tomographic devices. And that is where the Barrett TK formula, Barrett TK toric have become a very useful device and have improved refractive outcomes significantly. It is also very useful in post-refractive surgery eyes, and the Barrett TrueK has performed better than the ASCRS average, Sharma's, Haig's L. So instead of now looking at multiple formulae, I think Sheetal will be talking about post-laser refractive surgery eyes, but it has actually oversimplified the entire thing by saying that now you can just look at the TrueK, Barrett TrueK TK, and that is really a one-stop solution for post-laser, post-refractive surgery eyes. And just to show that TK doesn't work just with one particular formula, even if you apply it to another formula like the Haig's TK, it still performs better than the regular Haig's L or the regular Barrett TrueK without taking in the total keratometry. So as a concept, it works, and it works even with different formulae. Additionally, you also have the angle alpha and angle kappa measurements, which are also very useful, especially when you're looking at premium IOL surgery. Going on to anterior chamber depth measurements, this is very important, especially where most of the 4th and 5th generation formulae look at deriving the effective lens position as a very key indicator for outcomes. So measuring an accurate anterior chamber depth and accurate lens thickness becomes very important in getting the ELP. So the IL Master 500 measures from the epithelium, and also it was not very repeatable when it came to pseudophakic eyes. The measurements were not so accurate, but the other Scheimpflug devices were very good. IL Master 700, it has corrected that, and any of the swept source based biometry devices really give us a greater advantage because you have a direct foveal imaging which is now available. By directly measuring, looking at the fovea, we can tell whether the patient is fixating at the right point or not, and this is really improved in getting repeatable values. When you know that the patient is fixating correctly, your axial length and keratometry measurements are similar, and you also get a very similar and repeatable IOL power calculation. Whereas in this particular image, you can see that the foveal pit has not been imaged correctly, and this leads to a significant difference in the keratometry. And even though if it's just a 0.5 diopter difference and a 190 micron difference in axial length, it gives more than a diopter of difference when it comes to IOL power calculations. So it's very important that we ensure that the patient is fixating, and now we have a device which is actually telling us whether the patient is fixating properly or not. Like I already mentioned, because we are able to get better anterior chamber depth and better lens thickness values with the B-scan biometry, we are able to get a greater and more effective lens position mapping. We can also look at subtle macular pathologies, which can ensure that before the patient is being counseled, when you have this image, you know that they are probably not eligible for premium IOLs. You can even investigate further, get a retinal OCT done. And I'm not saying this is a replacement for retinal OCT, but it just gives you an idea before you subject the patient to other things. Again, the penetration with the OCT-based systems, OCT-based biometry devices is better, and even through denser cataracts, through dense posterior subcapsular cataracts, we get very repeatable values. Combining biometry with tomography, now we have a host of devices which are available, from the Antirion, the Lensa LS900, Aladdin, the IL Master 700. We have devices which are basically biometers, which are giving us a topographic measurement. We also have standard Scheimpflug devices like the Galilei, the Pentacam, all of which are now also coming in, which are compatible with axial length measurements. So, and like the G6 from Galilei and the Pentacam AXL also gives extremely accurate values. So how do they compare? When studies which have looked at comparing the results, biometry results from tomographers and biometers separately, have shown that they give us comparable IOL power measurements and comparable results itself. The Anterion has gone a step further, where you actually have excellent OCT-based topographic values, which are similar to that of what we can get with the Pentacam or the Galilee. The measurements, the anterior axial, posterior axial curvatures, the epithelial thickness maps, elevation maps are extremely good. You also get the ectasia indices, which are unique to this device, but again, very useful even for screening early grades of keratoconus. Within the same device, you also have various formulae which can be entered, and various IOL, different types of IOLs which can be entered, and you get the accurate biometry data. You have the toric IOL power calculations, which is already built in, which has the Barrett toric calculator and the Barrett Universal 2. So, and it also gives us an excellent anterior segment OCT. So it really has become a one-stop solution for topography, biometry, ASOCT in all ways, where you would have to use 3 separate devices all rolled into one, and also helps us in other measurements like the phakic IOL, the white to white, and even imaging the exact angle measurements, the scleral spur. All of these have become extremely useful. The other devices, like I already mentioned, do provide some data. However, they are all more of Placido-based devices and are not really a replacement for a tomographic device. The Topcon gives it as well. You get it from the Lenstar and from the ILMaster 700. But these are all rudimentary images and don't really replace a topographer itself. However, having the Barrett toric calculator or the Barrett TK toric calculator helps us in ensuring that every patient comes up with a toric calculation and you know whether to use this or not. So with this excellent array of imaging systems that we have today and the 5th generation IOL power formulae, emmetropia for all patients has become a real possibility. Thank you so much for your attention. Thank you.
Thank you, Dr. Shreyas, for that insightful talk about the array of biometers that we have. If there was one that you would choose, which would that be? Just for your practice.
No financial interest. They've not really given us any discount, but if I wanted to choose one today, it's the Anterion, because it really gives a one-stop solution for everything. Between Anterion, Argos and ILMaster 700, which we are using right now, I feel we are getting extremely good value from money from that device.
Thank you so much. I'd like to call upon our next speaker, Dr. Gaurav Luthra.
Oh, I have a question for Shreyas, because I'm using the Anterion 2 and for about a year now. I don't know if the mic is working, but there have been occasional outliers. Like we do biometry on 3 devices: the 700, the Lenstar, and the the Anterion. And especially for toric calculations, I found the axial length is a no-brainer, but the Anterion does anterior and posterior corneal measurements as well, and incorporates and gives you something like a true K kind of a thing, right? So the thing is that the 2 things don't match, the 700 and this, and the explanation given was that the tear film plays a role, and the Anterion kind of does away with the tear film because it's OCT based as compared to the 700. 700's Ks are more like measured from the, at least the anterior Ks are measured not from the OCT but from the, from those same number of points that were used in
yes,
the 500,
sir. The keratometric measurements is still the telecentric,
right.
Whereas the TK value comes from the posterior torus fit, which is SSOCT based.
The Anterion does both the measurements from OCT,
yes,
the anterior and the posterior, so they are sometimes different. So how do you decide if you're noticing a difference in the anterior, the true K values from the 700, and which one will you trust? Sometimes the ILPAR is off by half to 1 diopter.
We did a study, sir. We looked at especially these 2 devices first, ILMaster 700 and the Anterion, and it was quite repeatable. The only thing is with the Anterion, you need to use that software, which they give you 2 logins, and you can use the login to input the data and do it. But apart from that, with regards to the measurements, we didn't really have to do to get 2 different toric models between 2 different devices. That almost never happened. So that was a good experience that we had, and even published literature suggests that it is quite repeatable. So initially we were doing with both devices for all patients till we were comfortable. Now we just do any one based on where the patient goes.
So in our practice, we use the ILMaster 700 routinely and use the Barrett suite and we get excellent results. And as an all-in-one for topography and other things as well, we do have, as a refractive practice, we do have MS39 and other things which takes care of it. So that way, the ILMaster 700 works very well for us.
Yes. Like I said, ILMaster 700 is still, as for a biometry, is is excellent device. There's absolutely no problem. But the corneal topography which it gives is very rudimentary, and the CT version is all those who have the CT version of the IOLMaster 700 is it's not really adding too much value.
It's a good screening tool.
So it's just
a screening
yeah.
tool.
Even as a screening tool, it's only if it's grossly abnormal are you going to detect anything in it, and that's where the OCT based Anterion and works better.